Hi everybody, thanks for joining me for this board review of nutrition in the critically ill. When I was preparing this lecture, I reviewed the critical care medicine examination blueprint, and these are the details I found. In the different organ system disorders listed, there is of course no mention of nutrition, which probably means that there won't be many nutrition questions on your exam. But I thought this was the perfect occasion to review current guidelines and important literature. To do so, I'll use clinical vignettes and multiple choice questions, and we'll finish with some pearls. The main reference for nutrition in critical illness was published in 2016 in the Journal of Parenteral and Enteral Nutrition. It's the guidelines for the provision and assessment of nutrition support therapy in the adult critically ill patient, which are supported by the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition, or ASPEN. You'll know that I'm referring to a specific recommendation from these guidelines when you see the ASPEN logo in the corner. Let's start with the patient, Mr. S. He's a 70-year-old man who was diagnosed with gastric adenocarcinoma 2 months ago, and he's currently on chemotherapy. He is admitted with neutropenic fever and septic shock, complicated by acute respiratory failure and acute renal failure. So where do we begin? Step 1 is the nutrition assessment. ASPEN suggests a determination of nutrition risk for all ICU patients whom volitional intake is anticipated to be insufficient. There are 2 risk scores available, the NRS 2002 and the Nutrix score. They both determine nutrition status and disease severity. The NRS 2002 score isn't used much. It calculates a score based on patient's age, BMI, presence of weight loss, and severity of disease. The Nutrix score is the most used. It uses age, Apache 2 score, SOFA score, number of comorbidities, days of hospitalization prior to ICU admission, and interleukin 6 level if available. If IL-6 isn't checked, a cutoff of 5 or above is considered a high nutrition risk. Now, what about traditional lab markers for assessment of nutritional status? They are not suggested for use because they are not validated in critical care. So prealbumin and albumin shouldn't be checked. If you think about it, they are acute phase reactants, a reflection of vascular permeability, so they can't be accurate. Since you'll be working as attendings and billing for critical care soon, it's good to know that severe malnutrition is a critical illness. To support your diagnosis, you can document certain things in your physical exam, including loss of subcutaneous fat between digits or in the triceps region, muscle wasting at the temple, mandible, thenar and hypothenar eminences, or quadriceps. And finally, edema, whether it's anasarca or ascites. Returning to Mr. S. We determined that he's at high nutrition risk based on severity of illness and the fact that he's been losing weight. Next step is determining energy requirements. ASPEN suggests that indirect calorimetry be used to determine energy requirements when available, and in the absence of variables that affect the accuracy of measurement. Now there's a reason I'm sure none of you have ever seen a metabolic cart used before. They're big and cumbersome, and the majority of our patients have a contraindication to their use, such as an FiO2 above 0.8, the presence of an ET tube, chest tube, or continuous renal replacement therapy. So what's the alternative to indirect calorimetry? The use of a simplified predictive equation. Which brings us to our first multiple choice question. What are the average daily requirements in critically ill patients? 15 to 20 kilocalories per kg per day, 20 to 25, 25 to 30, or 30 to 35 kilocalories per kilogram per day? The answer is 25 to 30 kilocalories per kilogram per day. Of course, this varies depending on the patient's BMI. So for BMIs of 30 to 50, the average daily energy requirement is 11 to 14 kilocalories per kg of actual body weight. And if BMI is above 50, it is 22 to 25 kilocalories per kg of ideal body weight. What about average daily protein requirements in critically ill patients? Is it 1.2 to 2 grams per kilogram per day, 2 to 2.5, 2.5 to 2.8, or 3 grams per kilogram per day? The answer is 1.2 to 2 grams per kilogram per day. Keep in mind that when we make these calculations, we should use the patient's usual weight or dry weight if they're volume overloaded. And again, the patient's BMI will affect the recommended daily protein intake. If BMI is 30 to 40, then 2 grams per kg of ideal body weight are recommended. And if BMI is 40 or above, it is 2.5 grams per kg of ideal body weight per day. Now, what form of feeding should we use? Our options are parenteral versus enteral. And Aspen suggests that we use enteral nutrition rather than parenteral therapy. The reason enteral nutrition is recommended is because it's associated with a lower infectious risk. Now, how does enteral nutrition decrease infection? It helps to support functional integrity of the gut by stimulating blood flow and inducing the release of trophic endogenous agents. It also maintains structural integrity of the gut by maintaining villus height and tight junctions between the cells. What happens when the gut isn't being used, for instance, when TPN is administered? This leads to changes in gut-associated lymphoid tissue, which decreases mucosal immunity and ultimately decreases IgA levels in the small intestinal and respiratory tracts. It also promotes bacterial translocation from the gut, which is demonstrated by an increased fecal bacterial count and an increase in culture-positive mesenteric lymph nodes. Now, do more recent studies reach different conclusions? This study, published in the New England in 2014, did. In this study, they randomized critically ill patients without contraindication to either to be started on enteral nutrition or parenteral nutrition within 36 hours of admission and continued for 5 days. They found no significant difference in mean number of treated infectious complications and no significant difference in 90-day mortality. But this study had questionable generalizability since the patients all had intact guts. They received a maximum of 5 days of TPN, which is generally not the case when TPN is in fact started in real life. And more importantly, only 13% of their patients were considered malnourished based on BMI and recent weight loss. So enteral nutrition remains the preferred mode of nutrition. Step number 3, initiating enteral nutrition. How soon should nutrition therapy be initiated in critically ill patients? As soon as possible, within 6 to 12 hours of presentation, within 12 to 24 hours, or within 24 to 48 hours of presentation. The answer is within 24 to 48 hours, which is what Aspen recommends. Again, the reason is that early enteral nutrition decreases infectious complications, but a meta-analysis demonstrates that early enteral nutrition also decreases mortality. So practically, when can we start feeding? To keep this realistic, your nurse calls you. She's concerned about starting tube feeds on Mr. S because she doesn't hear any bowel sounds. Aspen tells us that while GI contractility factors should be evaluated, overt signs of contractility are not required prior to initiating enteral nutrition. Keep in mind that bowel sounds are indicative of contractility, but they tell us nothing about mucosal integrity, barrier function, or absorptive capacity. So you tell your nurse it's okay to start now. She tells you that they won't be able to place a post-pyloric tube until tomorrow. Should you still start feeding now? Well, fortunately, the Aspen guidelines suggest that it is acceptable to initiate enteral nutrition in the stomach, but to divert to lower in the GI tract in patients at high risk for aspiration and those who have shown intolerance to gastric enteral nutrition. And this includes patients with pancreatitis. They can be fed in the stomach. Nasojejunal nutrition was compared to nasogastric nutrition in critical illness, and there were similar rates of vomiting, aspiration, diarrhea, ventilator-associated pneumonia, and mortality. However, if you do need to obtain post-pyloric placement of a feeding tube, it can be done a few different ways. By video assisted placement, such as endoscopy, which really isn't practical, with the help of a magnet device such as the CoreTrack, or with the help of a prokinetic. So then the charge nurse calls you to express concern that Mr. S is on 2 pressors. What Aspen says about this is to wait until the patient is fully resuscitated and or stable. They go on to say that enteral nutrition should be held if MAP is less than 50 millimeters mercury and when pressor dose is escalating. That said, early enteral nutrition has been specifically examined in patients on vasopressors and mechanical ventilation. And they found a decrease in mortality for the early enteral nutrition group. What's even more interesting is that the benefit of early feeding was most evident in the patients treated with multiple vasopressors. Now, how quickly should we advance tube feeds to goal? Aspen recommends that in patients at high nutrition risk, feeds should be advanced to goal as quickly as tolerated over 24 to 48 hours. Now, by the end of your shift, the charge nurse calls you again to say that Mr. S's gastric residual volume is 420 milliliters. Here are the problems with the science behind the gastric residual volume. Having a gastric residual volume is normal. We all have a certain fluid content in our stomachs. The technique of checking the gastric residual volume is completely inaccurate. Enteric tubes have been shown to migrate between the antrum and fundus, so that depending on where they are positioned, how the patient is positioned, the size of the syringe used to aspirate, the size of the tube, you will not get reliable measurements. Another issue is that stopping tube feeds once a certain gastric residual volume is met has not been shown to decrease aspiration. And more importantly, aspiration pneumonia is not secondary to gastric aspiration. It is secondary to oropharyngeal aspiration. Luckily, in 2013, the effect of not monitoring gastric residual volume on risk of ventilator-associated pneumonia was examined in adults receiving mechanical ventilation and early enteral feeding. Their conclusion was that absence of monitoring was non-inferior to monitoring in terms of developing ventilator-associated pneumonia, which is why Aspen recommends that gastric residual volume monitoring not be used as part of routine care. They do suggest that if you work somewhere they are still utilized, that a cutoff of 500 milliliters be used before holding tube feeds. On your following shift, the nurse called to say that Mr. S just vomited and she wants to know what to do with the tube feeds. Vomiting is a manifestation of intolerance, same as abdominal distension, abdominal pain, high gastric residual volume, diarrhea, decreased passage of flatus and stool, and abnormal imaging. The ways to improve GI tolerance include ensuring that the head of bed is above 30 degrees, post-pyloric tube placement, and prokinetic agents such as metoclopramide and erythromycin. Metoclopramide is dosed at 10 milligrams Q6 or 5 milligrams in renal insufficiency, and it can be given IV or enterally. Its side effects include tardive dyskinesia and QTc prolongation. Erythromycin is dosed at 3 to 7 milligrams per kilograms per day, IV or enterally. Its side effects also include QTc prolongation, tachyphylaxis, and bacterial resistance, which is why we don't use it as much. Now, at a systems level, how can enteral nutrition therapy delivery be optimized? Design and implementation of a feeding protocol, the use of a volume-based feeding protocol, the use of a bolus enteral feeding. Having a feeding protocol itself was found to increase the percentage of goal calories provided. A volume-based feeding protocol is suggested, and a continuous infusion protocol is also suggested. Returning to Mr. S. On ICU day 4, he still isn't tolerating tube feeds. What should we do? Aspen suggests that we hold off on parenteral nutrition for 7 days in patients at low nutrition risk, but that we initiate it as soon as possible in severely malnourished patients when enteral nutrition is not possible, which is not completely concordant with the latest study on the topic that looked at early versus late parenteral nutrition in critically ill adults. This was a randomized multi-center trial of critically ill adults that were nutritionally at risk but not chronically malnourished. They compared initiation of parenteral nutrition within 48 hours versus after at least 8 days. Mortality was the same, but there were fewer infections in the late initiation group. So we eventually start parenteral nutrition for Mr. S. A couple of days later, you found out that Mr. S did poorly on his spontaneous breathing trial, but that he had done great on the prior day. What's happening here? It could be refeeding syndrome. When feeding is initiated, it leads to insulin secretion, which causes intracellular movement of electrolytes, including potassium, magnesium, and phosphate. The manifestations of refeeding syndrome include arrhythmia, heart failure, diaphragmatic weakness with respiratory failure or failure to liberate from mechanical ventilation, seizures, rhabdomyolysis, and generalized weakness. To avoid refeeding syndrome with parenteral nutrition, Aspen suggests administering hypocaloric dosing with adequate protein. A few more days later, you find out that Mr. S started tolerating tube feeds. At what point can parenteral nutrition be discontinued? When he tolerates 30% of estimated daily energy requirements, 40%, 50% or 60%? The answer is 60%. Now let's go over a few pearls. What if our patient was not malnourished and at low nutrition risk? The Eden randomized trial examined initial trophic versus full enteral feeding in patients with acute lung injury. They concluded that there was no difference in ventilator-free days, 60-day mortality, or infectious complications. The problem with this recommendation is that protein was under-delivered, and most importantly, patients at high nutrition risk were not included in the study. So there's more than one way to interpret their results, but if it makes no difference, why not just provide full nutrition? Aspen went on to adopt this as a recommendation, and they suggest that in patients with low nutrition risk and low disease severity, nutrition therapy can be held for the first week of hospitalization. They even go on to say that patients with ARDS or acute lung injury can be fed with trophic or full nutrition. They forget to mention that this applies to patients with low nutrition risk. Which brings us to an important point. What percentage of ICU patients reach their target goal energy intake? 25%, 50%, 65%, or 80%? It turns out less than 50% of patients ever reach their target goal energy intake during their ICU stay. Part of it is because of under-ordered energy goals, and another issue is inadequate delivery, which happens because patients are perceived as having or have poor tolerance. There's technical issues with enteric tubes, and patients are made NPO for tests, procedures, and surgeries. The American Society of Anesthesiologists recommend 8 hours or more of fasting after ingestion of fried or fatty food or meat prior to surgery. Enteral feeds contain fat, carbohydrates, and protein and are considered a fatty food. But they do mention in their 2017 guidelines that it's unclear if patients with cuffed ET tubes need to be fasted at all. Here are recommendations for reducing fasting times in enteral nutrition for our critically ill patients. You'll see that the maximum number of hours recommended is 4 hours, even for abdominal surgeries. There's even a group in Canada that studied a no-fast protocol for tracheotomy in critical care and found no complications. What's funny is that they had one aspiration event in the NPO group. Since there seems to be endless reasons to hold tube feeds, here is a list of situations that are not contraindications to enteral feeding. Imaging, presence of diarrhea or ileus, supine position, or when the head of bed is flat, prone position, neuromuscular blockade, and TTM or induced hypothermia. These situations may be associated with decreased tolerance, but they are not a contraindication to enteral feeding. Now, regarding what enteral formulation to use, there is no clear benefit of using any specialty formulas. As you can imagine, it would be difficult to prove that a particular tube feed changes outcomes. That said, in practice, renal formulations such as Nepro and carb-controlled formulations will be very helpful. Let's talk about additives. First off, amino acids. Glutamine. It's been found to decrease infectious morbidity in burn patients, but when it was studied in patients with shock and multi-organ failure, it was found to increase mortality. Arginine. It's been studied in combination with other amino acids, and the conclusion was the same. It increases mortality in septic and mechanically ventilated patients. There is insufficient data to recommend vitamin C, vitamin D, fish oil, probiotics, OKG, or thiamine, unless of course the patient is known to be thiamine deficient. Interestingly, supplementing a combination of antioxidant vitamins and trace minerals, such as those contained in a multivitamin, was found in a meta-analysis to decrease mortality. Now, a few words on nutrition in surgical patients. The combination of arginine and fish oil was found to decrease infectious complications and length of stay in elective surgical patients, proving once again that surgical patients are different from medical patients. This is why Aspen recommends the use of arginine and fish oil in post-op SICU patients, and they also suggest their use in severe trauma and traumatic brain injury. Let's wrap up. Out of their 52-page document, the Aspen Guidelines for the Provision and Assessment of Nutrition Support Therapy in the Adult Critically Ill Patient have a few bundle statements. Assess patients on admission to the intensive care unit for nutrition risk and calculate both energy and protein requirements to determine goals of nutrition therapy. Number 2, initiate enteral nutrition within 24 to 48 hours following the onset of critical illness and admission to the ICU, and increase to goals over the first week of ICU stay. Number 3, take steps as needed to reduce risk of aspiration or improve tolerance to gastric feeding. For instance, use prokinetic agent, continuous infusion, chlorhexidine mouthwash, elevate the head of bed, and divert level of feeding in the gastrointestinal tract. Number 4, implement enteral feeding protocols with institution-specific strategies to promote delivery of enteral nutrition. Number 5, do not use gastric residual volumes as part of routine care to monitor ICU patients receiving enteral nutrition. And number 6, start parenteral nutrition early when enteral nutrition is not feasible or sufficient in high-risk or poorly nourished patients. I want to finish by recommending the Critical Care Nutrition website. It is run by Derek Hyland and other members of the Canadian Critical Care Trials Group. Every 2 years, they systematically review all new literature and perform meta-analyses about every topic subset. So finally, good luck on your boards, and if you have any questions, please don't hesitate to reach out by email. Thank you.